Good morning, everyone, and thank you for being here today. I'm excited to introduce our presentation on dialysis versus conservative care. My name is Dr. Asim Hussain. Today, we'll explore the differences between these two approaches, discuss their implications, and look at how to make the best choices for patient care. We'll cover the key aspects, benefits, and considerations for each option. Let's get started. Now, let's look at this case. An 89-year-old man with stage 5 CKD, which means his kidney function is at its most severe stage. He also has severe heart failure with an ejection fraction of only 20%, indicating very poor heart function. Additionally, he has advanced dementia, recurrent hospital admissions, and is totally dependent in his daily activities. Given this complex clinical picture, the key question here is, what is the most appropriate next step in his care? Option A suggests arranging urgent AV fistula creation, but this is typically a preparatory step for long-term dialysis and wouldn't be the immediate priority in this scenario. Option B involves starting dialysis to prolong survival, but we need to consider his overall health status and quality of life. Option C offers conservative kidney management, which focuses on symptom control rather than dialysis, aligning more closely with his advanced comorbidities and functional dependence. Option D is referring him for renal transplantation, but at his age and health status, transplantation isn't usually a feasible option. And finally, Option E suggests initiating peritoneal dialysis, but again, we must consider whether aggressive interventions are appropriate for someone with his overall condition. So in cases like this, the most appropriate step is often to focus on comfort and quality of life rather than invasive procedures. That makes Option C, offering conservative kidney management, the most suitable choice here. Let's discuss why the correct answer here is C. Dialysis, as a treatment option, might sometimes be technically possible to perform. However, that doesn't automatically mean it's the best choice for the patient. When dialysis offers minimal benefit in terms of survival or improving quality of life, it may actually be more appropriate to consider other options. In fact, pursuing dialysis in such cases can sometimes do more harm than good, leading to unnecessary interventions without meaningful benefit. That's why conservative care, which focuses on comfort and quality of life without aggressive treatments, is both ethical and evidence-based in these situations. It's about prioritizing the patient's well-being and respecting their values, especially when the potential benefits of dialysis are limited. This approach aligns with the overall theme of patient-centered care, ensuring that our interventions truly serve the patient's best interests. Now, let's take a look at this scenario. We have a patient who insists on continuing dialysis, even though there's clear evidence that it will actually worsen their quality of life and won't provide any survival benefit. This brings us to an important ethical question. Which principle doesn't obligate us to provide dialysis in this case? The options are autonomy, beneficence, non-maleficence, justice, and clinical futility. The key here is to understand that while patient autonomy is a fundamental principle, meaning we respect their choices, there are situations where other principles come into play. In this case, beneficence and non-maleficence, doing good and avoiding harm, are crucial. Justice involves fairness in resource allocation. But when we consider clinical futility, meaning the treatment no longer provides benefit or may cause harm, this principle can justify not providing a treatment. So, in this scenario, the principle that does not obligate us to provide dialysis is actually clinical futility, because it recognizes when a treatment no longer benefits the patient and may even cause harm. This example underscores how multiple principles guide our decision-making, but they can sometimes point in different directions depending on the circumstances. Let's take a closer look at why Option A is correct. Autonomy, as you know, is a fundamental principle in medical ethics. It means that patients have the right to make decisions about their own treatment. However, this right includes the ability to refuse treatment, which is quite different from demanding treatments that are not beneficial. It's important to emphasize that clinicians are not ethically required to provide futile treatments. those that won't help the patient or improve their condition. Providing such care can sometimes cause more harm than good, and respecting patient autonomy doesn't mean fulfilling every demand, especially when the treatment offers no real benefit. So, the key takeaway here is that autonomy empowers patients to refuse treatment, but it doesn't obligate clinicians to provide non-beneficial or futile interventions. This distinction is crucial in navigating ethical decision-making in clinical practice and aligns with the broader theme of balancing patient rights with professional responsibility. So, when we're considering whether dialysis will actually extend life, especially in elderly patients with advanced CKD, it's important to look at different patient groups. The key question here is, in which of these groups does dialysis not provide a significant survival benefit compared to conservative care? Now, among these options, the group that stands out is the elderly patients with heavy comorbidities. These patients often have multiple health issues that complicate their condition. For them, dialysis may not necessarily translate into a longer or better quality of life. This highlights a critical point in our overall discussion, that treatment should be personalized. It's not always about doing more, but about understanding what truly benefits the patient. Sometimes, conservative management might be a more appropriate choice, especially when the potential survival benefit of dialysis is minimal. So, identifying these patient groups helps us make more informed, compassionate decisions about care plans, ensuring that we're aligning treatment with the patient's overall health status and goals. The correct answer here is C now. Let's delve into why that's the case. Studies have consistently shown that in very elderly patients, especially those with a high burden of comorbidities like cardiovascular disease, the survival benefits of starting dialysis are actually quite limited. This means that for some patients, the risks and the impact on quality of life may outweigh any potential extension of life. This is an important point because it highlights the need for careful, individualized decision-making. It's not just about the medical facts, but also about understanding the patient's overall health status, their goals, and their preferences. Throughout this presentation, we've emphasized the importance of a patient-centered approach, especially in complex cases like these. Recognizing when dialysis may not provide significant benefit helps us better align treatment plans with what truly matters to the patient. Now, let's look at this question about a frail CKD patient who is worried that starting dialysis will solve all their symptoms. But the key point here is that, in many cases, some symptoms may actually get worse or stay the same even after dialysis begins. The question is asking which symptom this might be. The options include hyperkalemia, fluid overload, fatigue, uremic pericarditis, and metabolic acidosis. Among these, fatigue is especially important to highlight. Even after dialysis, patients often continue to feel tired or weak. This is because fatigue can be caused by multiple factors in CKD, such as anemia, nutritional issues, or the general toll of chronic illness. Dialysis helps remove toxins and excess fluid, but it doesn't immediately resolve all the underlying causes of fatigue. This is a crucial point because it underscores that dialysis is a vital treatment, but it isn't a cure-all. Managing symptoms like fatigue often requires a comprehensive approach, including addressing anemia, nutrition, and overall health. So the correct answer here is D, uremic pericarditis, because it's one of the symptoms that can persist or even worsen after dialysis, especially if not treated promptly. Understanding this helps us appreciate the complexity of symptom management in CKD patients and the importance of a holistic approach to their care. Correct answer is C now. Let's talk about what happens after starting dialysis. It's important to recognize that many patients, especially frail elderly individuals, often experience fatigue, which can be quite overwhelming. Along with that, there's often a noticeable decline in their overall functional ability, making daily activities more challenging. This can lead to a loss of independence, which is a significant concern for many of these patients. These changes are quite common and highlight the importance of careful monitoring and supportive care, as patients begin dialysis. Understanding these potential challenges helps us better prepare and manage their health, ensuring we address not just the treatment, but also the quality of life during this transition. All right, let's take a look at this scenario. Imagine the family is demanding dialysis even though the patient previously expressed that they wouldn't want life-prolonging treatments. So, the key question here is, what should guide our decision-making in this complex situation? The options listed include family wishes, ICU bed availability, clinicians' personal values, patients' prior expressed wishes, and hospital dialysis targets. Of these, the most important guiding principle is the patient's prior expressed wishes. This reflects the core of respecting patient autonomy and their right to make decisions about their own care. While family input is important, it shouldn't override what the patient has clearly communicated about their preferences. Similarly, clinicians' personal values or hospital targets shouldn't influence the decision. Our primary obligation is to honor the patient's values and previously expressed wishes. And of course, resource considerations like ICU bed availability, though relevant in some contexts, shouldn't override the ethical obligation to respect the patient's autonomy. So, in this scenario, the most ethically sound and patient-centered answer is D, patient's prior expressed wishes. This helps ensure that we're making decisions aligned with what the patient would have wanted. This highlights the overarching theme of our presentation: balancing clinical judgment with respect for patient autonomy and ethical principles. The correct answer here is D now. Let's talk through why that is. Advanced statements and prior wishes. These are critical because they take precedence over surrogate demands. Essentially, if a patient has made clear their wishes ahead of time, those wishes should override what a surrogate might demand in the moment. This approach aligns with both ethical principles and legal standards, ensuring respect for patient autonomy. It's important because it emphasizes that respecting a patient's prior expressed wishes is not only morally right, but also legally sound. This concept ties into the overall theme of respecting patient autonomy and making sure their voice is heard, even when they might not be able to speak for themselves later on. Now let's look at this scenario: a ventilated patient with multi-organ failure who develops stage 3 acute kidney injury. As you can imagine, their prognosis is quite poor. The question here is, what best supports withholding dialysis in this context? Looking at the options, the key point is that sometimes, despite the severity of kidney injury, dialysis might not actually change the overall outcome. In this case, the answer is D, dialysis unlikely to change outcome. This highlights an important aspect of our decision-making, considering the bigger picture. If the patient's prognosis is grim due to multiple organ failures, initiating dialysis might not offer meaningful benefit and could even prolong discomfort or suffering. So this slide emphasizes the importance of assessing whether dialysis will truly improve the patient's chances or just add to their burden. It ties back to our overall theme of individualized, thoughtful care in managing complex cases like this. All right, let's look at the correct answer, which is option D now. The key point here is that dialysis isn't always the answer, especially if it doesn't improve the patient's chances of survival or help them recover. Even if the biochemical tests show abnormalities, if doing dialysis won't change the outcome, then it's not indicated. This emphasizes the importance of considering the overall clinical picture rather than just focusing on lab results. Remember, our goal is always to choose interventions that genuinely benefit the patient, and that means sometimes holding back if the treatment won't make a real difference in their recovery or survival chances. This concept ties back to our broader theme of making thoughtful, patient-centered decisions in critical care. So on this slide, I want to emphasize that a planned, active approach is key when managing CKD. It's not just about waiting and doing nothing. Instead, we focus on several important areas. First, symptom control, making sure patients are comfortable and their symptoms are well managed. Second, slowing the progression of CKD itself, which can help preserve kidney function for as long as possible. Third, providing psychosocial support, recognizing the emotional and mental health needs of patients and their families. And finally, advance care planning, having conversations early about future care preferences and goals. All of these elements come together under the umbrella of what we call conservative kidney management, or CKM. It's a comprehensive, proactive strategy that aims to improve quality of life and respect patient wishes, rather than simply opting for dialysis or transplantation as the only options. This approach clearly highlights that we're not just doing nothing, but actively working to support our patients in a thoughtful and personalized way. Now, let's discuss situations where dialysis may not be the best option. First, when a patient is severely frail, their overall strength and resilience are significantly compromised, making the burdens of dialysis potentially outweigh the benefits. Next, advanced dementia is a key factor. In such cases, the focus often shifts towards comfort and quality of life rather than aggressive treatments like dialysis. Heavy cardiovascular comorbidity is another consideration. When the heart and blood vessels are already heavily burdened, adding dialysis can sometimes do more harm than good. Poor functional status is also important. If a patient is already limited in their daily activities and independence, dialysis might not improve their overall well-being. Finally, limited life expectancy, typically less than 6 to 12 months, is a crucial point. In these situations, the goals of care often shift from prolonging life to ensuring comfort and dignity. This slide really ties into our broader theme. Understanding when dialysis aligns with a patient's overall health status and goals, and when conservative care might be a more appropriate choice. Let's take a closer look at the evidence snapshot. First, it's important to understand that dialysis can significantly improve survival, particularly in younger and fitter patients. These are individuals who are generally healthier and more likely to benefit from the treatment. However, when we look at very elderly patients or those with multiple comorbidities, the benefits of dialysis become less clear. In fact, in these groups, we often see little to no benefit from starting dialysis. Another critical point is that quality of life often declines after initiating dialysis. While the goal is to extend life, we also need to consider how treatment impacts a patient's overall well-being and daily functioning. Sometimes, the burdens of dialysis can outweigh the benefits, especially in patients with complex health issues. Finally, it's essential to compare dialysis with conservative care. For some patients, especially those who might not see a clear survival benefit or who prioritize quality of life, conservative care can be a viable option. This approach focuses on symptom management and comfort without the burdens of dialysis. Overall, these points highlight the importance of personalized decision-making, weighing the potential benefits and harms based on individual patient characteristics and preferences. Now, let's talk about the ethical principles that guide our decision-making in these complex situations. First, beneficence means we should always act in the patient's best interests, aiming to do good and promote their well-being. Next, non-maleficence reminds us to avoid causing harm. It's about ensuring that our interventions don't lead to unnecessary suffering or complications. Autonomy is also crucial. Respecting a patient's informed refusal means honoring their right to make decisions about their own care once they've been fully informed. Then, justice involves fair resource use, ensuring that we allocate healthcare resources equitably and without bias. Lastly, futility signifies that we have no obligation to provide treatments that are unlikely to benefit the patient or improve their condition. When we compare dialysis versus conservative care, these principles help us weigh the benefits and burdens of each approach. For some patients, dialysis might align with beneficence and respect for autonomy, especially if they wish to pursue every possible life-extending option. However, if dialysis offers little benefit and might cause harm, principles like non-maleficence and futility come into play, guiding us toward more conservative approaches. Ultimately, these ethical principles serve as our compass, helping us navigate complex decisions with compassion, fairness, and respect for patient values. Let's go over some key pearls about MRCP. First, dialysis is not automatically required when the eGFR drops below 10. It's important to remember that the decision to start dialysis should be based on the patient's symptoms and overall condition, not just lab numbers. Speaking of symptoms, it's also worth noting that some patients may actually experience an increase in symptom burden after starting dialysis, which highlights the need for careful patient assessment. Conservative care, or non-dialytic management, is actually an active treatment approach. It involves managing symptoms and maintaining quality of life without necessarily resorting to dialysis. This brings us to an important ethical point. Families cannot demand futile treatments. We need to ensure that the care provided aligns with the patient's best interests and realistic outcomes. In the ICU setting, decisions around renal replacement therapy are driven by the goals of care. It's crucial to have clear discussions about what the patient values most and what outcomes are achievable. When comparing dialysis and conservative care, the choice should always be individualized. It's about balancing the potential benefits with the burdens and always keeping the patient's wishes at the forefront. Ultimately, the goal is to provide compassionate, appropriate care that respects the patient's values and quality of life. Thank you so much for being here today. I really appreciate your time and attention. I hope you found this presentation insightful and useful for your work. Remember, the key points we discussed are all about understanding the importance of this topic and how it can positively impact your projects and decisions. It's been a pleasure sharing this information with you, and I encourage you to take these ideas forward and apply them in your own contexts. If you have any questions or want to continue the conversation, please don't hesitate to reach out. Once again, thank you for your engagement and interest. I look forward to seeing how you implement these concepts in your endeavors. Have a great day.